Hello, and welcome to Social Workers Rise, where we inspire social workers to connect, expand their knowledge, and change more lives than they ever thought possible. We will talk everything social work on every level from micro to macro. We are going to hear stories of social workers who are doing big things, learn new skills, and most importantly, give you actionable steps to make a difference today. Let's go. Hello, and welcome to another episode of Social Workers Rise. It is your host, Catherine here. Today, we're going to be talking about a brand new topic. Well, it's new for me. It's not new for our guest, but we're going to be talking about advocacy and unions and her involvement during the 10-week strike at Kaiser. I'm super excited for these juicy details. Let's hop into it. Ilana, welcome to the podcast. Tell us a little bit about who you are and what you do.
Thank you, Catherine. I'm really happy to be here. I was thinking you'd say something like Ilana bringing the rise to Social Workers Rise. So really happy to be here on behalf of NUHW and the mental health workers that we represent. So I got into social worker. I like to say that social working called me in. My parents were foster parents, so I was raised in a home with a lot of siblings, one biological and many non-biological that came and went as this foster system operates. And when it came time to really grow up and figure out what to do, the relationships that I had with my foster siblings and their social workers, I just thought how neat it was that they could develop a career of really supporting and making an impact on a young person's life. And, to be honest, I juggled from major to major and interest to interest a lot. And I kind of felt like I continued to circle back to how do I have a meaningful impact in the world? Yes, I need to make money. My family instilled that value into my skull, survival, etc. But money really didn't drive me as much as making an impact did, and as much as having something that let me sleep better at night, living in a chaotic world where things like abuse and oppression are happening, right? So yeah, social working chose me through the relationships I had to my own foster siblings, their social workers, and I just couldn't stop. Once I was on track, I kept going.
Yes, and I think that's a similar story that a lot of social workers have. I know I have that same story where I wasn't a foster kid, but I was in situations exposed to social workers and in a place where I just needed extra help, and my family needed extra help, and social workers happen to be, the ones that are there and during some of the lowest points in your life, and the ones who provide resources and provide that hope and that change, right? That you can rise up. And I'm so not catchy, so I love your intro about the helping us rise.
Into the work.
Yeah. That was one of my feedbacks. So side note, I survey my people every year about what can I improve on the podcast, and they're like, you should be like Steve Harvey and be a lot more funnier.
Oh my goodness.
I wish I could do that, but that is not my talent. If you're here to laugh your ass off, it's not going to happen. So you're going to have to go to Steve Harvey's podcast for that. But thank you for sharing, your intro story. And it sounds like you are making a difference, and on a micro and macro scale. I love this hybrid that you have going on with your work. So tell us first about, what is it that you do during the day for your job?
I'm a licensed clinical social worker. I work in adult psychiatry for Kaiser Permanente in Oakland. So we see a host of mental health needs and I work on what we call the onset of care. So I have a split role. I do 2 different jobs in our clinic, but both are at the very beginning of an episode of care. So the first role is I am a triage therapist, which means I'm doing that initial screening. The moment you tell your doctor you're depressed, the moment you call into your health plan to say, I need to speak to a therapist, a referral is generated, or a direct transfer live call is generated into our clinic if it's during our business hours, where you speak to someone like me and do a brief 10 to 15-minute screening to ensure the patient is safe, to understand if there's any immediate medical needs. Does this patient need to go to the emergency room, or can I book an initial assessment or another next step for them, depending on the reasons for their call? So I'm doing that 10 to 15-minute screening, sometimes longer if there's any crisis involved. We do have a lovely crisis team, so I don't have to stay with the crisis for very long. I'll give it a warm transfer to our very skilled and awesome crisis team. Shout out to the Oakland Psychiatry CRT team. And then I also have scheduled initial appointments. So after they've gone through an initial screening and the clinician has determined that, they don't need immediate care, they're not at risk of suicide or homicide or any imminent threats, then they book an initial assessment with someone like me. And we go through the full mental status, background, employment, cultural identity, faith. It's about a 15-minute interview, and then more time for the patient to really dive into the reasons they're seeking care. We use feedback-informed care tools, questionnaires that are online that if needed, I facilitate in the meeting. Most of the time, the member can do that ahead, so that we get some data. How acute is the patient? How severe? What are the main complaints? What is my diagnosis? And then we treatment plan. Do I get you with a therapist in the clinic? Do I generate an external referral? Do I send you somewhere else in the health plan? Because something like, the normal response to grief can be supported through our bereavement services, through hospice department. In order to get care in psychiatry, you have to meet medical necessity by the DSM. So if you're having a mental health episode that we can't classify in terms of medical necessity, there are other resources that we give members in those cases. So my job is to really understand the need and help set the treatment plan up for that member.
This sounds like a lot. It sounds really interesting, but it also is just a reminder of how much you need to know and that background knowledge and the foundation of knowledge that you need to have to be in a position like yours. Because I also worked in the hospital, and I often get asked, why is it necessary to have your LCSW to work in the hospital? And I always tell them, because you need to be able to be comfortable with a range of different topics, from elders to domestic violence to children and child abuse to moms having babies, drugs, OD, like all sorts of different areas. You need to at least have the foundational knowledge about, the questions to ask, the assessments to use, and also the resources that might be available, immediately, and where to refer them, how to triage. So I love that you're able to do all of that and to give us, a background on your job. I'm wondering, what is the deal with the strike of 2022? Because I do remember hearing about it. I remember it was a really big deal. 10 weeks, that's a long freaking time. So tell us what happened and why was that necessary?
Well, work stoppage 101. If you don't want your workers to go on strike, you keep an active contract. The law does not allow workers to just walk out of the job if there is a contract in place that I can depend on as a worker in terms of what are my benefits, what are my pay, what are my working conditions. and the employer can be secured that their workforce will be there day in and day out. So the first thing that happened is that Kaiser radically delayed our negotiations and allowed our contract to expire. And a strike is a last resort. We don't start by just going, oh, that contract's done, deuces. We give feedback internally. We participate in professional practice committees, feedback-informed care meetings, clinical consultation. A strike should never be a surprise. And so what I really want to impress upon your listeners is that if you're hearing about any strike in the media, the first thought should be, gosh, I wonder how much had to happen on the inside for us to get here, right? Because we represent 2,500 mental health care workers in the Northern California Kaiser region. And we're just Northern California in my unit. We have a Southern California unit that is close to where I know you call home. That's brewing. Their contract is almost about to expire come the fall. And Kaiser has only 2 bargaining sessions planned between now and then. And for anyone who's involved with any negotiations, especially with such large groups of employees, that doesn't happen in 2 meetings. We're talking about wages. We're talking about benefits. We're talking about our own family members being able to access our own mental health care needs without having to be seen by my coworker in the office next door. Right? We're talking, and you said, wow, that's a lot about the work that I do. It is a lot. We're a factory. Kaiser Permanente, I am attracted to it, and I stay there because we serve the people. Most of my friends and family members have Kaiser. I'm a Kaiser baby. I wasn't born in a Kaiser, but I've had Kaiser health care since I was a child. I have delivered 2 of my own babies in Kaiser. I'm a Kaiser member. My family are all covered by Kaiser. Most of my friends have Kaiser as one of their best options. So what keeps me at Kaiser, even though it feels like a factory and our employer doesn't always listen to what we need and what our patients really need? It's really the patients. I have the opportunity to see patients who otherwise would not have access to mental health care because of Obamacare, because of mental health parity legislation, which we've been very instrumental in pushing our lawmakers to carry forward. We've sponsored mental health parity bills that require health plans to respond to mental health needs in a timely fashion. That define mental health as health, right? If you have chronic untreated PTSD, the likelihood that you have high blood pressure is very high. The likelihood that you're going to suffer from a heart condition is very high. Mm-hmm. So our position is that if we swim upstream and really center mental health as health, we're going to save the state money. We're going to save these private health insurers money. We're going to save California residents and patients money. Mental health is health. And so we spent 13 years before our strike, maybe 12 or 13, over a decade, Catherine, where we have been banging at the boss's door day in, day out in our local clinics and our local sites, saying mental health cannot be treated like a factory conveyor belt where I just fix depression with a screw and a nail, and our patients are staying sick. They're waiting for their appointments before the strike. As an initial assessment coordinator, if someone needed care within the health plan, and there's criteria around whether I refer out and in, et cetera, they'd have to wait between 2 to 3 months. depending on where I was booking. And so before I worked for Oakland specifically, I worked for the Connect-A-Care, which is the regional call center. It's 180 mental health therapists doing initial assessments through telehealth. It's grown during the COVID pandemic, but we were telehealth about a year and some change before the pandemic too. So good thing, we had that started. But nonetheless, we tried and begged internally to reduce the wait times, to hire more of us, to get us out of the factory. I sort of have in the Lucille Ball image of just like, can't stomp the grapes fast enough. And that's how we've been feeling about mental health for a long time. And so our contract expired. And then I was also on our bargaining team, and there was about 23 of us that join in the bargaining sessions with our employer and our union negotiator. And they would show up late. They refused to bargain because we did a one-day Martin Luther King strike some months before the open-ended strike, because our employer had promised to give us Martin Luther King Day off and then retracted it. And that made a lot of members upset, especially our African-American clinicians and all of their allies. Like, you just don't do that on the backs of Black Lives Matter, George Floyd's death, and everything that everyone was really experiencing in 2020. So we went on a one-day strike and just said, you're not going to give it to us. We'll take it. Yeah. And so it was a lot of work on the inside. And then, that's right. They turned off their cameras. They just turned them off and left, even though we had a scheduled bargaining session. And all of us on the bargaining team showed up to bargaining on that day, ready, good faith. Let's talk, let's pass proposals. We had already sent them some proposals. We were waiting to hear some of their feedback. They just didn't like that we were on this one-day strike, and they turned their cameras off, and that was that.
Wait, I'm sorry. So this is upper. Right. This is upper.
We did a few short ones before. Yeah.
Okay. Yeah. So this is like upper management turning off their cameras.
Mm-hmm.
Oh my gosh.
Just logging off, even though we had hours of bargaining scheduled. Right. And then we would show up and they'd, we'd say, okay, here's our proposal. Here's why, some of us would give some testimony. Here's why we need this in the contract, et cetera. And they would just sort of nod and say, we're uninterested. We're uninterested. We hear you, but we're uninterested in that proposal. And then SB 221 is a state law that requires health plans to provide timely access to mental health care, but specifically return and follow-up appointments have to be within 10 days unless a clinician and the patient, unless the clinician determines that more time is appropriate. And that happens, right? But more often than not, it's the other way around. I only have an appointment in 3 months, and I'm being told to just document that they need it in 3 months. Like, instead of me determining as a skilled and trained clinician what I am recommending for a patient based on evidence-based practices, and evidence says you front load care and help someone now, and higher acuity would be more like weekly. And then as the patient progresses, you fade out every 2 weeks and beyond. But it's the opposite. It was the opposite at Kaiser, where you wait 2 to 3 months in the beginning when you most need it, and you get worse. And we wonder why our hospitals and our ED rooms are filled.
Yep.
Right.
They're going to keep coming back.
Right. And so that's why SB 221 was put in place. But the law passed years before it took effect. And that was because the health plans were like, it's going to take us a long time. Like, you can't just implement this now. We have to hire. We need systems in place. And so the state was very generous and gave Kaiser about 1.5 years to figure out how they were going to follow this law. And so that law took effect July of 2022, sometime before our strike. And as that date passed, they were expected to be implementing. Like, that wasn't That wasn't the, okay, now let's start thinking about it date. That
Right.
happened a year and a half ago. That was the, okay, now's the day you're supposed to follow the law. And they showed us no evidence on the inside that they were following that law. They'd give us no information in bargaining, no reassurance that there are plans in place to start following that law. So that really fanned the flames. People were disgruntled. People, and by people, I mean our clinicians,
Yep.
were disgruntled, upset. Imagine just being the mental health therapist that is attracted to this work to help your community, but you have to tell sick patients day in, day out, I know you need this care, but you have to wait 3 months to get it.
Ugh. Talk about that moral injury. Oh my gosh.
Right. Right. And so that moral injury, that dehumanizing, demoralizing feeling grows.
Yep.
And it grew enough within more than 2,000 of our members that after enough bad faith bargaining from the employer, after this law taking effect, and we saw no evidence that they were taking it seriously, we saw no evidence that the state was penalizing Kaiser for ignoring the law, we said enough is enough. And so we went on strike. What was it? Mid-August of 2022. And said, we'll come back when you settle a contract.
And what was your role during that strike? Because we mentioned kind of offline that you were talking to the media. What was your role and how did you get involved in that?
I was loud. So I've been a steward since 2019, and a steward within a union, for those that don't know, like, we are the workers on the inside that serve as representatives to the union. We are the ones that sit in on corrective actions, make sure the employer plays fair and follows our contract, because union staff are not on the job. They're not in the clinics. They can't regulate the employer and make sure they're following our contract. The workers have to do it. And so stewards are elected leaders in their clinics. So I'm an elected leader of Oakland Adult Psychiatry. At the time, I was an elected leader of the Connect to Care call center. I was pregnant when our negotiations started. So I was on maternity leave or pregnancy leave that then became maternity leave. I missed our second bargaining session to be in labor. But there were many. So, yeah, valid. And so a steward is someone who stays on the inside and pays attention. So I was a steward when the strike happened. And as I mentioned before, I was also on our bargaining team. So I was face to face with these high paid, high senior executives that would just dismiss every plea we made over and over and over again. So just imagine the fire. If you, I think mental health therapists, we show up with good faith. Like, what could be going on for somebody else? Like, when we get yelled at by a patient, we have to regulate ourselves and go, okay, well, there's trauma behind that. It's not personal. We have training and lots of work to just do our own healing and work on our own countertransference so that we can stay present. And I think that, going into bargaining, I still had this sort of I understand the barriers, and mental health is expensive. And I was giving Kaiser grace and understanding that we've been in a mental health crisis longer than this COVID crisis. And I imagine the COVID crisis was, it took healthcare some time to adapt, right? It was a trauma on the system, if you will.
Yes.
But going into so many of those bargaining sessions and just seeing the disregard and seeing some of their facial expressions, and some of them looked busy, like they weren't even listening, and they were doing other things on their Zoom camera. And then they would just say things like, "Thank you. We are uninterested in that proposal." No discussion, right? And when you've poured your heart out and given patient testimony about the experiences that you the vicarious trauma we live with, how do we deal with that when we're going in and out from patient to patient to patient? One of the big issues for bargaining was indirect patient care time. So the time you use to call a parent if you're a child therapist, or the time you use to send their primary care physician an update, or to request labs or other things that need to be facilitated if we're doing an ADHD test, etc. All that extra work, documentation. We have a legal duty to document our clinical notes. We were not given that time. Patient, 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 boom, 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 boom. We were working after hours routinely, and they just refused to acknowledge that. They would say
That's
things like,
exhausting.
yeah, your salary, right? So they would use that we're exempt employees when it benefited them. But then in other ways, someone had a no-show and they walked across the street to grab some coffee, and came back and took care of their patients. Well, people would get in trouble for little petty micromanagement, things like that. But I thought we're salary. I thought that's what the benefit of being an
Right.
exempt employee is, that you get to do things like that. If so long as we're showing up during the scheduled appointments and following our contract,
Right.
we're grown-ups, we're professionals, right? So it was just a really toxic work environment for too long, and folks were tired. So my role was that I wasn't quiet, never been quiet. We didn't have any stewards in the Connect to Care just before our strike, and the mismanagement of the COVID-19 pandemic really pushed me forward. I won't get into the details, but the summary is that they should have sent us home long before they did,
Okay.
because I'm working in a call center, right? Tight, crammed space of mental
Yeah.
health operators almost. And a pandemic is breaking ravage and scaring everyone in the media, and they refused to send us home until the governor twisted their arms and made them send it home, which we had weeks of exposure and contact before. So the mismanagement of the pandemic, alongside a handful of other hot topics internally, where the culture really was to just ignore and ignore. I still have an attorney mother. So the concept of justice and fairness was definitely a value I was raised with, alongside, if you have something that someone else doesn't, you open your home and you share. She was a foster mom also, right? And so I think these values put together, I felt like I had to speak up. I mean, it
Yeah.
was it was my livelihood. It's the colleagues around me in the break room, and all the stressors that we experienced, and feeling like they wouldn't hear us and wouldn't respond. When you become part of a union and when you are a steward, the laws say that you are equal to management. So while my manager is in charge of me in terms of my work, my clinical work, she's my manager. When I am a steward and I'm talking about large scale worker issues, I'm talking about our contract, I'm talking about fairness in the workplace, I am their equal. And they have to respond to us in a way that they don't have to respond to you as an individual employee.
Interesting. I
So
never knew that.
I wanted, hey, if the badge was going to get me listened to and allow me to be a voice for many of my colleagues who felt intimidated to speak up, or spoke up a lot and were just never heard, they didn't see changes. If this badge was going to get me some power and some decision, our voice to the table, so be it.
Yep. 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 Love it. Yeah. That's amazing. Hey, it's Catherine here. I hope you are enjoying this episode. We're going to take a quick break to listen to these ads from our sponsors. The next time you need continuing education units, I highly recommend the Therapist Development Center. When I started this podcast, I reached out to the founder, Amanda Rowan, to see if she was interested in being a sponsor. And she jumped at the chance to support her fellow social worker. TDC has helped more than 100,000 social workers pass their licensing exam, including myself. I love that TDC CE courses are engaging and relevant. Amanda and her experts give us clear and practical clinical skills that we can immediately apply to our work. Some of my favorites are the Edge of Life Suicide Prevention course, where Amanda shares her personal experiences And they did what? Law and ethics course that looks at real cases where therapists face formal disciplinary actions. They also have a great telehealth course. We are legally required to take continuing education to increase our competence, and most other courses out there don't actually teach the material in a way that we can learn it, but TDC does. You can also check out the links in the show notes. I'm wondering, what were the changes that you saw as a result of the strike?
Yeah. Well, maintaining a strike is difficult, and we made massive gains. So I want your listeners to know that our strike was effective. We have a much better contract as a result. We have higher wages as a result. We have better benefits for our own mental health and the mental health of our family members. We also developed a number of model of care committees, which were labor management partnerships to expand mental health programming within Kaiser. That some of that work has already taken into effect. So I'm telling patients I have an appointment for them in return access most of the time. We're starting to slip
Great.
again. But right after
Okay.
the strike, I will tell you about 95% of my patients, I had an appointment for you within 10 days. No fight with my manager.
Wow.
Pushback. Yeah, it was a night and day, right? It was a huge mental health care benefits in terms of what we can offer our patients. That's starting to slip a little. So it's important to stay active and diligent when you
Yes.
are in a union and working for a massive corporation. But nonetheless, those gains were significant enough for enough of us to stay. We lost a lot of therapists. I think a lot of therapists saw the employer's true colors, saw how easily the employer would just let us stay out for that long. So there were consequences, but consequences are what come when you abuse and exploit 2,500 mental health workers that are keeping your ship afloat.
Yes, definitely. I know lots of consequences for everybody, for the organizations, for the staff, because you guys now have to pick up the extra work, and then also
Yeah.
for the patients as well. I'm wondering if there's social workers or other mental health professionals who are interested in unionizing. What advice do you have for them? Because this is a topic that comes up a lot around my community, at least, as far as like, what can we do? Who's going to stand up for us? How do we even start a union? What are our steps? What advice would you have for someone who's thinking about this?
Do it. The advice is do it. If National Union of Healthcare Workers, we are growing every single day. So if you need help forming that union, join us. You can go to nuhw.org to learn how to organize your workforce. And we welcome all healthcare workers. So even though behavioral health and mental health is a central value of our union and expanding access to mental health, we have RNs, clerical staff, nurses, hospice, home care workers. If you are in the healthcare industry and you want to unionize, you can join us. You can make your own union, right? I mean, there are laws that basically say that once workers have asserted their right to collective bargain a contract, they are entitled to union-based protections. What those are and how those operate, most people don't really understand. So our website, can help you understand your rights as a worker and your rights to organize. And that leads me, if I could talk a little bit about our BAM project, because right now we're in the midst of organizing the less organized clinicians of our industry, and that is private practice therapists.
Yes. Yes,
We
please
have,
share.
thanks, Catherine. I mentioned that we refer externally a lot.
Mhm.
And the current system, it is the cost of that therapy, the payment, the terms of an external referral is 100% in the hands of the health plans. Therapists have no say. It's a take it or leave it deal. And, last I learned, and this was closer to the strike, so maybe it's changed, although I doubt it. It's about $80 for an hour of psychotherapy. And most private practice clinicians are charging well above that. I've learned this from your podcasts and many others. We are valuable, something I really love from your podcast, Catherine. We are valuable. And I am with you in rejecting that martyr complex where we don't ask for and expect what we know we need and deserve to stay sustainable in the work. Like if I don't have my oxygen mask on and my kids aren't eating and I don't have my basic needs met, I'm not going to help you with your depression. It's just science, right?
Yep.
And so $80 for an hour for someone who is licensed and gone through and spent the amount of money it takes to get this far in our careers is just a slap in the face as far as I'm concerned. It is chump change for the skills and training that a clinician has to go through to be able to sit in the room and legally practice psychotherapy with a patient. The private practice therapists have no voice. They're not at the table negotiating with the health plan. So that's a big part of why we're organizing BAM, Behavioral Health Alliance. Behavioral Health
Associate Membership Program.
Yes, Catherine. Get it. Thank you so much. Yes. Yeah, and you can Google BHAMNUHW. We have a new website there. So if you are a private practice therapist, please do check us out and join us. We have already started to organize a lot of clinicians, and our goal is to start negotiating with these insurers to get you the wage you deserve, but to also smooth over some of the other issues, because there's a lot of other issues that happen in these ghost networks where there's just no regulation and patients are just left scrambling to find therapists. And therapists are either booked in full or they're not, but nobody knows they're not. And so how do we get them clients? We really need massive overhaul to the private practice system as well. And that's part of what we're doing with our BAM members.
Yes, so important. And the link is in the show notes. So go ahead and open up your podcast app, go to the description, and you can click on that link that she was talking about. And so, Ilana, you also have 2 patient advocacy bills that NUHW is sponsoring in the California legislature. Did you want to talk about those for a little bit?
Absolutely. So we have already been instrumental in passing SB 855 and SB 221. 855 defined mental health as health. So that's the parity laws that we can refer back to. And I'm sharing the background because they build on each other. And then 221 is the return access and timely access to care bill that says you shouldn't be waiting more than 10 days unless your clinician says more time is okay per your treatment plan. And so those laws are in place. But the problems we're facing now is that the state does not have the resources to hold the health plans accountable to those laws already on the books. So what good is a law if nobody is enforcing it? And so AB 3221 really is about enforcement that gives the Department of Managed Healthcare more enforcement power. It increases the efficiency and efficacy of their ability to act and enforce these parity laws. And it also allows the DMHC director to take disciplinary action when health plans fail to respond to a member's request for care in a timely manner. And it really just clarifies that the department's role is to enforce and supervise. Before our strike, the relationship between the big health plans and the state was cordial. It was, dare I say, old boys club of just like, oh, you're following the laws, right? Oh, of course we're following the laws. The laws are so important. Oh, good job. Thank you for following the laws. And thank you for giving so much care to our to the Californians,
Right.
And it was just very like, that's not accountability. The
Mm-hmm.
state's job is not just to be a business partner. The state's job is to regulate and supervise and hold profiteers accountable. They are collecting Californians' premiums. They should be using those premiums to pay for your mental health care because the law says mental health is health. So if you meet criteria and we've determined it's medically necessary, the law says you need to give it, and the law does not let you give it in 3 months. So 3221 really just, one could say the state should be doing its job already, but the state says it doesn't have the capacity or the staff to do its job. So we believe the legislature needs to act to give the state that authority to enforce and allocate the resources to do it. And then the rider bill that builds on that is AB 3260, healthcare coverage reviews and grievance processes. Right now, consumers often don't receive behavioral health care because either they can't wait, they're functionally impaired, and they can't afford private practice. So those who can afford, those with more economic privilege, just give up on their health plan already, even though they're paying their premiums and their health plan should be giving it to them. They go outside and find a more expensive private practice, and they get help and they get well. Even though those dollars should have been through their health plan. Or they can't afford it and they stay sick. Or, dare I say, they die because suicide rates are really high, gun access is very high, and our mental health pandemic is not improving, especially given a lot of the barriers to mental health care. So then what happens if you make a request and they say, wait 3 months? Well, historically, you go through a lengthy internal grievance process. The law currently says that they have to respond to any grievance or care appeals in 30 days. I made an appeal before our strike, and I waited a year for that outcome. I have 6 letters sitting at home that says, we have your appeal. We're still working on it.
Oh my gosh.
We have your appeal. We're still working on it. 6 that lasted a year when the law says they should have had an answer for me by 30 days.
Wow.
So filing grievances internally doesn't lead to good outcomes for patients. And then, once you filed internally, that is when the state will listen to you. So the state, before our strike, if I had called them while I'm waiting for this process, they would say, have you made a complaint internally? And I'd say yes. And they would say, well, what was the outcome? And I'd say, I don't know. I'm still waiting.
Right.
And they would say, well, let us know how it goes, right?
Oh my gosh.
Until it's done, we don't step in. That's the agreement with their old boys club, little, cordial, diplomatic, less accountability based relationship. So it basically meant that the state was futile and people wouldn't do that. And all of this, we're talking about functionally impaired folks. If you're too depressed to get out of bed, you're not going to get up and go through a lengthy appeal process and, dare I say, call the state to get them to do the job for you too. So 3260 is the solution to that problem, to ensure that patients have timely access. So it really empowers patients in the grievance process and in their care requests process. So it prohibits health plans and disability insurers from overriding urgent determinations made by healthcare providers. So let's break that down. Status quo, somebody with a business and finance degree is making a clinical determination on whether or not you needed to get care when you file an appeal or a grievance. What? Like if my leg is cut off, I don't need a finance person to tell me whether or not I need medical care. I
Right.
need a doctor,
Yes.
right? And so 3260 puts those decisions back into the clinician's hands. We as the clinician determine, is this an urgent request or a standard request? If it's urgent, then the health plan has to respond in 72 hours. If it's a standard request, mild to moderate symptoms, fine. 30 days seems appropriate.
Mm-hmm.
So it puts it in the clinical determination is what generates how timely they have to respond. And it also clarifies consumers' rights to file grievances concerning a lack of access to care and requires the health plans to initiate a grievance on a consumer's behalf when they fail to respond in a timely fashion, right? So historically, we are relying on loud customers. Only the loud customers willing to do the work, to do the grievance and the appeal
Yes.
will get heard in the status quo.
Yes.
This law will say if it's an urgent request because the clinician says so and the health plan didn't respond in 72 hours, the state is favoring the state will make a decision that favors the patient.
Okay. That's good.
No ifs, ands, or buts. So it motivates them to do their job, right?
Yes.
If it's a standard complaint, you have 30 days. Do your job in those 30 days, right?
Yep.
And if you don't do your job in those 30 days, then the state's going to make a decision that favors the patient's care needs.
As it should be.
So it would automatically resolve the grievance in favor of the patient.
Yeah.
And then the last thing it does is it changes the requirement to 72 hours for urgent. So that's a new piece.
Nice. Yeah, so powerful. Because I know I've told many patients, you will not get seen or heard or your wishes request if you stay quiet. The squeaky wheel gets the oil. And unfortunately, it sucks to be putting that pressure on sick, grieving people. I mean, they're just trying to take their meds on time, right? Keep their meds straight. And then here you are having them saying, you got to be the squeaky wheel. It's a lot of pressure. So I'm glad that these changes are happening, that these are coming. And I love that there is an open door for social workers and mental health professionals who want to be involved in more macro work, because the clinical social workers, they have the stories, they know the solutions, they see the gaps in the systems, and they know what needs to be done. And so I love that this is the open door for them to say, hey, join up with this organization, do the work. If you're interested in starting a union in your own area, then this is a path to get some help and support around that. So thank you so much, Ilana, for sharing everything. Did we cover everything? Is there anything that we missed?
Yeah, unions rock. Join a union and keep rising, social workers, and reach out to us if we can be in partnership in any way.
I love that. Thank you, Ilana. Thank you so much for your time.
Thank you.
Thank you for listening to another episode of Social Workers Rise. If you love this episode, be sure to subscribe and text this episode to a friend. If you want more, there are a few ways we can get to know each other and work together. First, definitely subscribe to the Friday resource email list. The link is in the show notes. And that's where you can learn more about the courses I offer, including Clinical Essentials for the Future Therapist and the Pulse Basics for Medical Social Workers. I'll also be sending out occasional tips and resources and other happenings within the social work industry. And for all your clinical supervision needs, be sure to visit risedirectory.com. This is a national directory of clinical supervisors for social workers, and we also provide free resources that you can use within your own clinical supervision. Lastly, if you have more individualized needs, I do offer coaching, individual consultations, and am available for public speaking engagements for social workers and change makers. Lastly, the boring legal stuff, but very important. The information in this podcast is not meant to be a supplement for therapy, professional advice, or clinical supervision. This content is provided as is solely for informational purposes. It is not legal, health, or safety advice. I am not advising you as a therapist. Organizations should engage their own experts to ensure any adopted measures are compliant with applicable laws and standards in their jurisdictions. The opinions expressed by individuals or organizations are their own and do not reflect the views or opinions of Social Workers Rise or Catherine Moore. References to specific products or organizations do not constitute any endorsement or recommendations by Social Workers Rise.